So good morning, everybody. I'm Dr. Gagan Bhatia, and I would like to thank all of you for being here. So basically, I think amniotic membrane grafting has been in vogue for a long time with anterior segment surgeons using it as a good biological in ophthalmology. It was only when we started using this in retina and macular disorders that one day Dr. Rushad in the OT told me that, you've started stealing our amniotic membrane as well. So that basically kind of conceptualized this course. That is where I kind of thought that, why not have an integrated course where we discuss the use of this technology or this graft, where we combine and share our knowledge, between the anterior segment and the posterior segment. With the same sentiment in mind, this course was put into place, and I'd like to thank the AIOS Scientific Committee for accepting this for presentation today. So the course basically will be first starting with the basic sciences of amniotic membrane grafting, which will include how these grafts are procured, what is the technology behind the graft, and what makes it a safe biological. Then it will be taken over. We go through the anterior segment indications as well as the techniques to use it. And thirdly is the newest, which is amniotic membrane grafting in retinal disorders. So this basically changes the way we use it because being very fragile and transparent membranes, procuring and using the graft or the technique to use is extremely different from the anterior segment disorders that we use. So with not much ado, I would like to introduce my panel, which basically includes Dr. Sandeep Kumar, Dr. Rushad Shroff, Dr. Darayesh Shroff, and myself, Dr. Gagan Bhatia. Unfortunately, we don't have Dr. Ritu Arora with us today because some exigencies, and her talk would be taken over by Dr. Dipinder Chauhan. So for the first talk, I would like to invite Dr. Sandeep Kumar, who would be talking on the science and clinical potential of amniotic membrane graft in ophthalmology.
A very good morning. I'll be discussing on the science and the clinical potentials of amnion membrane graft in ophthalmology. The amniotic membrane, a biologically active extracellular matrix, has emerged as a pivotal tool in ophthalmology regenerative medicine. Its anti-inflammatory, anti-fibrotic, and pro-regenerative properties provide a unique therapeutic advantage in both anterior and posterior segment pathologies. This presentation dwells into the anatomy and cellular mechanisms related to the clinical application.
Slides are not moving, I think. Now they move.
So the fetal development is achieved by a complex system consisting of umbilical cord, amniotic fluid, and placenta. The fetal membrane basically consists of an outer chorion layer and the inner amniotic membrane, which is a thin membrane on the inner side of the placenta. It completely surrounds the fetus and delimits the amniotic cavity, which is filled by amniotic fluid. It's a translucent biological structure that has no nerves, muscles, or lymph vessels. Its thickness varies from 0.02 mm to 0.5 mm and consists in the three main histological layers: the epithelial layer, the basement membrane, and the avascular mesenchymal layer. The epithelial layer has cuboidal cells which are firmly attached to the basement membrane, which is a condensed acellular composed of collagen 1, 2, and 5. Amniotic membranes, epithelial cells, have microvilli at their apical surfaces and probably have an active secretory function. Going back to the history, in 1910, Davis used amniotic membrane for skin for the first time because of its tensile strength and its inert nature. After that, Stern and Sabella in 1913 used amniotic membrane for the management of skin, burns, and superficial wound, basically on its anti-inflammatory properties. After that, it gained attractive treatment became an attractive choice for the treatments with the genitourinary tract, oral cavity, skin, stomach, larynx, and head and neck cancers. It found its way to in ophthalmology in 1940s when D. Roth first used for conjunctival reconstruction. After that, it gained popularity when Kim and Singh used it for multiple pathologies in 1995. Over the years, advancement in preservation techniques have expanded their application in ocular surface and retinal diseases. Now we'll be discussing about the amniotic properties and applications. The main objective of MTR ocular surface reconstruction, promotion of epithelialization, providing symptomatic relief, and reducing inflammation. Now, the scientific basis for the use of amniotic membrane graft for transplant are these anti-inflammatory, anti-fibrotic, pro-regenerative pluripotency, immunomodulatory, and biocompatibility. We will be discussing them one by one. So the amniotic membrane, the derived cells possess pluripotent properties, making them an attractive source for transplantation. These cells can differentiate into all three germ layers, the ectoderm, mesoderm, and ectoderm, and they also have stem cell markers. They have been seen to differentiate into hepatocytes, cardiomyocytes. They have been helpful in cartilage repair and insulin production. The anti-inflammatory characteristics are because of the production of anti-inflammatory factors like IL-1 and IL-2 receptor antagonist, IL-10 and endostatins. In addition, it also produces alpha-1 antitrypsin, which is a protease inhibitors and has an anti-inflammatory effect. This is further promoted by increased apoptosis of neutrophils following the application of human amniotic membrane to therabit corneas following PTK throughout the expression of pro-apoptotic ligands CD95 on the surface of mesenchymal cells. Amniotic membrane is a promoter of epithelialization. The composition of amniotic membrane not only provides a physical barrier, but promotes the migration of epithelial cells and their differentiation that leads to strengthened adhesion of the basal epithelial cells. It also produces platelet-derived growth factors, human growth factors, keratocyte growth factors that promote survival, proliferation, and migration of epithelial cells. The anti-angiogenic properties maintains the avascular surface of the cornea, preventing the new blood vessel formation. The production of anti-angiogenic compounds such as thrombospondin 1, endostatin, and tissue inhibitors metalloproteinase has been demonstrated in vitro in human amniotic membranes. Amniotic membrane suppresses TGF-beta receptor and the factor signaling in fibroblasts, reducing fibroblast activity and the differentiation of fibroblasts into myofibroblasts. This process results in the reduced scar formation with less scarring observed in corneas treated with AMT following alkali-induced damages. The membrane also produces intrinsic antimicrobial properties, improving outcomes in bacterial keratitis compared to the antibiotics alone. Cells of AM produces beta defensins, antimicrobial peptides expressed in mucosal surfaces. In addition, it also demonstrates antiviral properties attributed to its expression of cystatin A, suppressing the viral infection that has been helpful in the herpes simplex keratitis. It has an immunomodulatory effect, demonstrating limited HLA-1A and 1B antigen. This leads to minimal immunological rejection, eliminating the need for immunosuppression post-AMT. Now, the preparation and technique parts. The placenta is procured at cesarean section, preferably an elective one. Meconium-stained placenta or with high crust are avoided. This is collected from OT in sterile drape and brought to laminate flow bench. The peeling of onion is done after finding out a plane and is then gently washed using plenty of sterile water. It's finally stored in 50 ml sterile container containing about 1 gram Genta, 1 strepto, and 10 ml of fluconazole. It's capped and mixed by inversion several times. It's stored in refrigerator till ready for cleaning and after getting the viral markers clear. The cleaning is done in sterile tray using soft brush, and the care is taken to clean all the blood and gelatinous material sticking to the matrix side. The media preparation consists of water, 1 gram gentamicin, streptomycin, and 25 ml fluconazole, and the pH is adjusted. The cryoprotectant media is prepared using this medium and 50% glycerol. Filtration is done via 0.2 micron syringe filter, and finally 1 vial of amphotericin B is added to the cryoprotect aseptically. The sterile membrane filters are used to stick the amniotic membrane matrix side down and then cut to size 3 centimeter by 3 centimeter and roll filled to 2 ml sterile vials. These vials can be stored at below -20 degrees for at least 1 year before use. Now the storage part, which is the mainstay, is cryopreservation. This process involves placing the amniotic membrane in storage solution in a 1-to-1 ratio of 86% glycerol in Dalbec modified Eagles medium and storing it in -80 degrees Celsius. Stable storage at this temperature allows the membrane to be used for up to 1 to 2 years. However, the preservation concerns about potential damage to the amniotic membrane integrity due to its crystallization within the tissue. This can reduce the anti-inflammatory effect and the antiogenic intermediates. The second one is lyophilization, which is freeze drying for amniotic membrane. It involves rapidly freezing it to -80 degrees Celsius, followed by the use of high vacuum to dry the tissue, and this eliminates the need for cold storage and logistical challenges associated with cryopreservation. The third one is the dehydration, which involves placing the membrane in a vacuum and dried at -3.5 to 6 degrees Celsius after removing the spongy layer and pre-treating it with raffinose and incubating with the broad-spectrum antimicrobials. It has been seen that the application of lipoprotective saccharides such as trehalose or raffinose has been demonstrated to preserve the biochemical stability of multiple growth factors and enzymes crucial to the antifibrotic and anti-inflammatory properties of amniotic membrane. Both fresh and preserved amniotic membrane have been found to function equally well when transplanted onto ocular surface. However, there are certain concerns when using a fresh AM. With fresh AM, the short time interval from the tissue procurement to transplantation prevents repeat testing of the donor. Patients have been brought to the hospital at short notice, unlike with preserved AM, which allows more flexibility in the scheduling surgery. A distinct disadvantage being the wastage of the unused tissue. Let's look at some of the commercially available amniotic membrane preparations. New Vision makes OmniGen and OmniLens. OmniGen is available in multiple forms with epithelial side up, clearly marked for the proper orientation during the application. And it comes in various diameter according to size and in various shapes, rectangular and square sheets. The other being OmniLens variety, which is it combines preserved amniotic membrane with soft contact lenses, allowing for sutureless application in clinical settings without requiring a surgical theater. The biotissue uses cryopreserved amniotic membranes, the main being the AmnioGraft and AmnioGuard, both produced in various rectangular sheets. The AmnioGuard is a thicker one and is specialized for additional tissue support. Ocufix 2 is a gamma-irradiated and processed aminoglycoside antibiotic membrane. It can be stored for an impressive 5-year shelf life, and it's available as a 16 mm disc sheet or various square or rectangular sheets. Finally, the Visio-Emitrix, which is a lyophilized amniotic membrane, and it can be stored at room temperature for up to 5 years. Recently reported as an effective treatment for persistent epithelial defects when applied in sutureless fashion with a bandage, simplifying the application process. Now, all these deeper insight in the properties of amniotic membrane has led to has revolutionized and expanded its role in the ophthalmology. It has been, it's found its way through ocular surface disorders in corneal ulcer, persistent epithelial defects, pterygium surgery, Steven-Johnson syndrome, surface reconstructions, glaucoma filtration surgery, and has been started to use as a scaffold in optic disc maculopathy, which will be discussed by the subsequent speakers. So amniotic membrane grafting represents a significant advancement in ophthalmic care due to its regenerative, anti-inflammatory, and anti-scarring properties. Its established role in ocular surface disease and expanding application in retinal surgery highlights its clinical potential. Continued research and innovation will further refine its use, offering hope for improved patient outcomes in challenging ophthalmic conditions. Thank you.
Thank you, Dr. Sandeep. I would just want to ask you that, so basically, I think that there's a very extensive introduction to amniotic membrane. And so just for the general use, I think, anyways, as ophthalmologist, I don't think we all have access to a gynae lab. So what is the way of procuring? I mean, do we very easily get it for use, or just for the general practitioner, like how easy is to procure the membrane and use it?
We generally use the cryopreserved through the wet AMG bank. We have it is available very easily on contacts only.
Right. Yeah. Okay. And so, anybody from the audience, I mean, any experience with a dehydrated graft? If anybody used that, or any questions? So, from the cornea side, I think.
I don't think we found it very useful to use dry amniotic membrane. It is used, I think, by the glaucoma specialists. Sometimes they have been using that, the dehydrated amniotic membrane. For corneal indications like chemical burns, it doesn't seem to work very well. Although now, this in terms of you can procure cryopreserved, there are some companies which are selling it as well. So that is becoming more readily available, the wet membrane through that. So,
right.
So it can
Thank you. So thank you, Dr. Sandeep. For the next talk, I would like to call Dr. Rushad Shroff. He's a cornea refractive surgeon at Shroff Eye Centers, and he'll be talking on inlays and outlay amniotic membrane grafting in corneal pathologies.
So I'm going to be talking about the traditional use of amniotic membrane.
Can we have his slides, please? Yeah.
Before our retina colleagues here decided to steal the membrane. So let's go ahead with what we usually use it for. And the most common indication is chemical injury, and that we've seen. These are true ocular emergencies. Generally, the incidence is more in males compared to females. These result in significant cosmetic and visual disability. And you have the various different etiologies. We know that alkali burns tend to do worse than acid burns. Lyme is a very important cause for this. Tuna or plaster injuries, they are extremely toxic. It's retained very strongly, and therefore it keeps leaching out chemical, which causes more damage. Ammonia in fertilizers, refrigerants, etc. also causes damage. Potassium hydroxide, magnesium hydroxide, these cause thermal and alkali injuries. Acids, we've seen that sulfuric acid in industrial cleaners and battery acids, it combines with water to produce corneal injury and maybe having associated foreign bodies. Sulfurous acid, hydrofluorous acid, all these tend to cause a lot of damage. Hydrofluorous, due to its low molecular weight and small size, it penetrates deeply and rapidly. and causes quite a deep kind of injury to the cornea. So the first thing in these is clinical assessment. It's very important to actually determine the grading of the injury. You have the Duas and the Roper Hall classification, which I'll come to. Very important to double evert the eyelid, see for any retained material, because that continues to leach out the chemical. The initial treatment is copious irrigation. It's important to rule out any globe injury, and it's treat first, go into detailed examination later. The dictum is to irrigate, irrigate, irrigate. So we had the traditional Roper Hall classification, which talked about corneal involvement and limbal ischemia. And it's classified as grade 1, 2, 3, and 4, with 3 having a guarded prognosis and 4 a poor prognosis, where the cornea becomes opaque and the iris and pupil details are obscured with greater than half the limbus involved in terms of limbal ischemia. The only issue with that was there was no talk of conjunctival involvement, and we've seen that conjunctival involvement is also very important in determining whether these patients will do well after treatment or not. And therefore, the Dua's classification incorporates conjunctival involvement, and it's got an analog scale that gives you a percentage, and therefore it's graded 1 to 6, and then you tend to have better understanding of which patients would do better, and grade 5 and 6 being the one with the poorer prognosis. So the severity, like I mentioned, depends on the type of chemical. Alkali does worse. The surface area of the contact, the depth of contact penetration and concentration, and the degree, of course, of limbal stem injury, because it's the limbal palisades that actually bring about regeneration of the non-keratinized epithelium that covers the cornea. So the major principles in management are to try and re-establish the corneal epithelial surface in terms of non-keratinized epithelium, rigorous control of inflammation, and a control of the intraocular pressure, because that tends to rise in chemical injuries because of the damage inside the anterior chamber. So medical management includes topical steroids to control inflammation. You may have large epithelial defects initially, but it's important in these cases to actually start steroids quickly, because the first 8 to 10 days you want to start steroids. Afterwards, it can be counterproductive and cause collagen melt. So it's important to control the inflammation initially. Cycloplegic drops for symptomatic relief, antibiotic eye drops as prophylaxis, lubricants to promote epithelial healing. Ascorbate in terms of vitamin C helps to repair and minimize ulceration, and you can have things like doxycycline added in for protecting the collagen. N-acetylcysteine has also been used and been found to be useful. We reconstitute it with something called mucomix injections. You mix it into a lubricant, and then you can reconstitute and use that on the ocular surface. Now, if you look at this would be a grade 1 injury, and you can follow these up after a few days of medical management. They tend to do better. As you go to more severe injuries, you can see that even after medical management, there is not significant improvement. It's important to stain the ocular surface in all of these, because you get a much better understanding of the extent of the injury when you actually use fluorescein to stain this. So these are various papers talking about the surgical role of amniotic membrane grafting in chemical injuries. And that's the crux of the talk. You can see here that on staining, the cornea is quite significantly involved, as is the limbal. There's limbal ischemia along with conjunctival ulceration. Now, if there's a large epithelial defect involving the cornea and the cornea plus maybe 50% of the conjunctiva, look at amniotic membranes grafting. If it's corneal plus greater than 50% involvement of the conjunctiva, then you'd look at something like an AIOS or a mucosal graft. If the AMG does not bring about significant healing of the cornea, then again you would look at these particular procedures. So we have to understand what is a good outcome in this. The role of AMG in a milder injury is first to control the inflammation. In a moderate, you can have reepithelialization of the surface. In a severe kind of burn, you're not trying to actually ensure that the epithelium grows back because the limbus is quite damaged. In that, you're trying to ensure that the surface is at least a little hydrated, it recovers to an extent, and then you can, of course, go in with an AIOS or another procedure to re-establish the non-keratinized epithelium. So these are a few surgical videos of how to use the amniotic membrane graft. As Sandeep had mentioned, this is the wet membrane, which can be peeled off the paper, the filter paper that it comes on. In chemical injuries, it's important to try and cover the the surface all the way up to the lid margin, because you can have involvement of the lid margin by the chemical injury. You can see here you're holding, the epithelium is up, the basement membrane is down, the chorion side, and you're covering right up to the edge. You can reposit it, put some fibrin glue, which comes from either Baxter or Eliseel. No financial disclosures there, and then you would tend to reflect the conjunctiva, the amniotic membrane back over this, and then follow the same procedure in the lower half. You can just reflect the lower half of the amniotic membrane. Make sure that you tuck it well into the fornices to avoid fornicial foreshortening as you go forward. And then we can use either continuous or interrupted sutures to actually anchor this into place. You can see here the glue being applied again, and then the similar process being adopted here. This is a case where we used a double-layered amniotic membrane. It's a persistent epithelial defect with a melt, so we're using a smaller area of amniotic membrane first. We dry off the surface around it. We reflect and place it in the right orientation. We then ensure that we place the glue and then place this over that. Following this, the larger area of amniotic membrane coverage is done. You can use brimonidine to actually reduce the conjunctival hyperemia. Sometimes when you're anchoring these near the limbus, you can have a little bit of bleeding under the amniotic membrane, so it's important to use that as topical preparation for these kind of cases. And you can see then you can trim the excess amniotic membrane, otherwise that tends to fold up. Following this, slit has been discussed. It's a very good way to actually re-establish a non-keratinized epithelium once the initial insult has been taken care of by the AMG. You can see here you do a 360-degree conjunctival peritomy. Once you've done an AMG prior, then you get a cleavage plane, and it's easier to actually then dissect this out and actually peel it off the surface, and then you'll get a much better visualization below this to actually go ahead with the slit. Dissect off any areas of symblepharon, cut off the sutures, and then remove this entire membrane. How to prepare the slit? A donor tissue from the other eye in an allogenic slit. You basically mark on the conjunctiva, you dissect towards the limbus till you see the gray zone, till you get a decent frill of conjunctiva. Watch for the appearance of the bleeding vessels. Dissect along the gray area, and that's where you get the limbal palisades. Generally, we take the graft superiorly because that's where they are the most high in density. And then we take this off, and you would prepare it. You would cut this into smaller tissues, smaller kind of implants that you place, explants that you place in a concentric manner on the cornea, and then apply the AMG over this and to anchor it in place. Generally, you see a very good clearing up of the ocular surface. Remember that if there's a very deep level of scarring, you may still have some amount of corneal scarring later. Once you've re-established the surface, then you can look at adjunctive treatments like a penetrating keratoplasty or a DALK if in those cases, if it can be done. So this is just to show how the slit plus conjunctival autograft tends to clear up over a period of time, even in quite severe chemical injuries. The last video I'm showing is that of a recurrent pterygium. You can see that pterygium tissue has come back. We are using anchoring sutures just to help us to move the globe. We are creating the conjunctival autograft on the temporal side. This is the area of the pterygium being marked out, where we've just seen how large an area we have to take the conjunctiva from the opposite side for dissecting this out like you would do in a normal pterygium surgery. We'll also use the amniotic membrane in this particular case to help with the recurrent pterygium. We've seen that the recurrence rate goes down, and its subsequent recurrences don't tend to happen as often if we use this. I'll just try to skip ahead a little bit. So they're marking out the area with the pen, the marking pen, the gentian violet pen, and then creating a conjunctival autograft. Ensure when you're creating this that you take minimum amount of tenons, reflect forward towards the limbus so that you get the orientation in the correct manner. And here we used this along with the amniotic membrane to actually place that. You can see here we are just preparing the area for the amniotic membrane, cutting off the excess conjunctiva, placing this. Then we will reflect this, place the amniotic membrane under that after we've sutured one end of it to ensure that the conjunctival autograft does not fold over. So they're just taking a couple of these sutures towards the nasal side and then placing the amniotic membrane. You'll trim it down to the right size here. Place it over the cornea, reflect the conjunctival autograft, place the glue over there, and then move the membrane after that. Again, place the conjunctiva over this, reflect, and then remove the excess amniotic graft. To conclude, chemical injuries are true ocular emergencies, and therefore staining with fluorescein is very important use of initial medical management, but amniotic membrane has a big role to play in controlling inflammation and restoring the surface. AIOS and additional procedures like tassuraphy also have a role in these kind of cases. Thank you. These are acknowledgements to the cornea department at Shroff Eye Center and Dr. Sharon and Dr. Ikeda for providing a couple of the videos. Thank you.
Thank you, Dr. Ushad. Just a couple of questions. When would you consider an inlay or AMG in case of corneal diseases? Would you use it as in a chemical burn or where there is a melting process?
In a melting process, I think we can consider an inlay. In a chemical burn, I would initially start off with just placing one layer of AMG and see how it responds. And then, of course, like I mentioned, we can look at slit and adjunct procedures at a later stage.
One thing that I have noted is in acute chemical injuries or in case of severe melts, it's better to use perhaps a double layer of amniotic membrane so that we get the right cleavage when the next surgery is being done, because it basically also prevents the corneal melt. Many a times when we do the dissection for the subsequent slat, when the pannus is being removed, then we realize the cornea itself is quite thin. So maybe just doing a multi-layer of amniotic membrane may be helpful in these cases.
Yeah, in melts, it does make sense to do that.
So, Dr. Ushad, just two basic questions I wanted to ask. So I remember my old, very simple question, but I remember my old residency days when I was not a retina surgeon and I was using amniotic membranes. I used to always suture them. So, take hours and hours suturing the amniotic membranes for ocular surface. So, are we like, it is just that the glue seems to be the new dictum to use, or it's...
We use glue, but we use sutures with the glue also. We don't only place glue. Generally, we do place sutures. Normally, either you can do a continuous suturing or you can do interrupted sutures to anchor it, but we do that.
Right. And the second thing was that obviously your handling of the membrane, because you're using larger grafts, is way different than what we use. So I think visualization probably is not a problem at this, when you're using it on the ocular surface, under direct view of the microscope. But do you, are you using then any sort of, reusing these membranes, and what are the sterilization process? So if you, like, at least for retina, if we use one sheet, I think we discard the rest of the membrane and not reuse it because it is an intraocular procedure, though it's been proven to be absolutely non-inflammatory. But in your case, is a single sheet used for every case, or you kind of divide it into many cases?
No, I think we try to post more cases on the day that we are using the amniotic membrane. We try not to use the same sheet multiple times. That's one thing. Amniotic membranes can still have infections, so I don't think we can kind of reuse it over a very long period of time either. So we prefer not to
right.
reuse
And because it does come in a glycerol medium, that's the most common medium. So any pre-preparation of the membrane that you do with antibiotics or something before you use it, or?
Not really. The Dulbeco medium is fine that it comes with. We don't pre-prepare it in any particular way. Also, there has been a lot of discussion on the orientation of the membrane, but practically it does not make a difference whether you place the epithelium side up or down. There are conflicting views on this, but I don't think there's any conclusive evidence on whether one is better or the other.
Right. And the one thing that you just mentioned was that brimonidine kind of helps decrease the bleeding in ocular surface. How does that happen, and does it help
basically,
otherwise also?
it causes vasoconstriction. So that's used in lots of things. LASIK also, people use it to reduce subconjunctival hemorrhage. It's just to kind of reduce the bleeding under the amniotic membrane.
Right. Thank you. Any questions from? Yes, please, sir.
Sure. Can you share the address or number of the person who is providing wet amniotic membrane?
Yeah, I have it on WhatsApp. If you want, we can project. I don't know whether we can project it here, but I can share it
Yeah,
to you.
we'll share it with you. We'll share the number. So next, I would like to invite Dr. Dipinder Chauhan. He's again a cornea refractive surgeon at Shropshire Centers, and he'll be talking on amniotic membrane grafting in ocular surface reconstruction.
So thank you, Dr. Gagan. As Dr. Sandeep and Dr. Ushad have already described the, the main idea of amniotic membrane and why it is so useful, I will skip these slides which basically emphasize that amniotic membrane is basically helps in cell differentiation, prevents cell death, and elongates the cell life. It's important one of the most important characteristic for which it is used in reconstruction is because one, it is one of the thickest basement membranes, so it gives you a better template or a substrate while being used for reconstruction, and second, it also reduces the scarring. This is especially important in conditions like symblepharon, chemical injuries, where we know that there is a lot of fibrovascular scarring which is likely to come back again after the surgery. So, as Dr. Ushad said, that it's not the epithelial viability which is important. It's basically the membrane is being used as a matrix or a substrate, and therefore putting which side up or down is not that important. Coming to ocular surface reconstruction, so the objectives of ocular surface reconstruction are most importantly to establish the epithelial cover that prevents stromal melting. It also limits the scarring and also limits inflammation. The common indications in which you would use ocular surface reconstruction is, apart from chemical injury and Stevens-Johnson's, when you're removing a large area of conjunctiva. This could be a conjunctival tumor or a large atypical or double-headed pterygium, and also where you expect there is recalcitrant scarring like a recurrent pterygium, a symblepharon release with fornix formation to adjust the prose lens, post-chemical injury, and even in contracted socket. Now, it's important to understand that amniotic membrane is not a complete solution. There is still a very high rate of failure in amniotic membrane grafting, especially when there is a significant stem cell deficiency. So large areas of conjunctival loss also, along with stem cell deficiency, will end up with a failure rate of 44%. And in spite of some residual stem cell deficiency, if the area of resection is very large, again the failure rates can be high and you may end up doing a repeat procedure. So the simple indications we described, that if you have to remove a large tumor, so the large bare area is covered with amniotic membrane, and I'll skip that video because it was just the basic video how to place an amniotic membrane. I would like to discuss the role of using slat along with amniotic membrane grafting in conjunctival tumors or in stem cell where there is a large area of stem cell deficiency. As you can see, this large tumor occupies almost the whole of the ocular surface, and to remove it, it's going to leave behind a large area of deficit. So the options here are, one, we can use an amniotic membrane, a large size amniotic membrane, and perhaps take out a slight small amount of conjunctival tissue from the other eye, or we can use the slat again from the other eye because there is also associated stem cell deficiency here. In case of OSSN excision, it's important to maintain the no-touch technique. While sending it for histopathology, it's important to mark the areas so that the orientation is right. Because in these tumors, there is also cryo which is being done on the margins, so the ability of conjunctiva to heal back is slow, and therefore again amniotic membrane becomes important. Here what you see is a mini slat being done, is a proper slat being done in this area because the amount of dissection is large and almost there is a complete stem cell loss.
Now, acute injury, Dr. Rushad has covered very well, and it is important that in acute stage, role of amniotic membrane is basically to reduce the inflammation, prevent the chances of melt, promote healing, whatever it may be conjunctival painus or it may be an epithelial healing. Studies have shown that amniotic membrane is extremely important in acute Stevens-Johnson syndrome patients, especially in grade 2 and 3, where it greatly reduces the probability of uh, persistent epithelial defects in the cornea and also associated stromal melt. However, an amniotic membrane cannot prevent a stem cell deficiency. That has to be covered by, that is basically the role of systemic immunosuppression, which is very important in the early stage of Stevens-Johnson's. Now, looking at this clinical outcomes in the recently published report by the American Academy of Ophthalmology, it has shown that in moderate grade burns, that is Roper Hall grade 2 and 3 or Dua classification grade 3 and 4, amniotic membrane significantly improves corneal reepithelialization. However, there is no statistically significant difference in the improvement of visual acuity. This statement might give you an impression that then what is the role of amniotic membrane grafting in these patients? It is important to understand that reepithelialization, early reepithelialization provides faster healing for the patient, and then sequelae of chemical injury in the form of symboliform are also much less in these patients. So visual acuity is one parameter, but then the health of ocular surface is much better in patients who have had an amniotic membrane graft. And another thing that Dr. Rushad said, that in these patients in acute chemical burns, using an amniotic membrane greatly improves reducing the invasion or the invasive painus formation, and therefore it is much easier to remove the painus in subsequent surgeries. The video that we are seeing here is basically an old patient, an old case of chemical injury with a persistent limbal ischemia. And here we had put an inlay graft of amniotic membrane because there was underlying thinning of the sclera. And over that, a free conjunctival graft was made. Now, it is important, I wanted to show you this video because there is one step which is missing here, and perhaps that would have been to bring the tenons capsule to the margins of the limbus so that it brings along with it more vascularization and the limbal ischemia is also addressed. This is highlighted by this patient in which there is a large area of 360-degree scleral and limbal ischemia, and there are no blood vessels right up to 3 to 4 millimeters from the limbus. In this patient, tenoplasty was done and 360-degree coverage of tenons was provided to the limbus, which provided a much better vascularization and improved the chances of subsequent success for the subsequent surgeries. Similarly, multi-stage procedures are required in patients who have extensive ocular surface damage, when at the end of it you get more gratifying results. So, another important group of patients which benefit from amniotic membrane graft are patients who have a recurring pterygium. It is important that these patients have significant scarring. They have variable adhesions at different levels, so the dissection is going to be equally traumatic for these patients. You have to use more cautery because the chance of bleeding is more. Therefore, you actually enhance the chance of limbal stem cell deficiency in that area and also chances of scleral ischemia. As Dr. Rushad showed in this video, basically the amniotic membrane being used here was to reduce the subsequent chances of scarring and recurrence of this pterygium. So here we had basically used this as an inlay along with a conjunctival limbal autograft. This is the last video that I would like to show, and this is, I'm going to play full. This shows again a recurrent pterygium, and here you can see that there are multiple levels of adhesions which can be seen. Even the eyelids are stuck onto the pterygium surface. This patient has a very dense fibrovascular tissue which is very invasive. These patients cannot be easily managed with an amniotic membrane because we know that by the time amniotic membrane would dissolve, that is maybe a matter of 1 to 2 weeks, there would still be an extensive amount of inflammation which will persist in the surface. These patients do very well with a mucous membrane graft. It helps you to also form the fornices and also prevents the chances of significant scarring, which is very, very likely after just an amniotic membrane graft. Once the mucous membrane has been done and fornix forming sutures have been placed, there is a mini slit which is being done, and it is once the amniotic membrane here is being used to cover the corneal surface, and also to provides you a template over which you would place the slit tissue. So amniotic membrane in alone may not be sufficient in patients who have very significant scarring, and it can at best being used as an adjunct for that particular reconstruction that we are planning. So it's important to understand that presence of limbal and conjunctival stem cell is very vital to the success of ocular surface reconstruction. You should avoid patients with infected surface while planning a ocular surface reconstruction. Also, patients with severe loss of limbal stem cells, large tissue defects, and exposure on neurotrophic insults require additional care. So with that, I would summarize. Thank you.
Thank you. Thank you, Dr. Dipinder. Just a question, you mentioned for scarring you would do an MMG. Any way that you would decide on the amount of scarring and when you take this decision, and do you combine SLET in all these cases, or when would you take and how would you take that decision?
So in a recurring pterygium, for example, especially when you are not the operating surgeon for the case before, then this is the first time you are operating, your clinical judgment depends on two factors. One, while you are dissecting, how much is the plane, how much is the damage to the underlying scleral surface, how much is the dissection that you have to do. Also, to look at the health of the donor tissue. The conjunctival tissue, if it has been taken once before, you will have more fibrosis and scarring, and therefore the subsequent chances of survival of that conjunctival autograft will also be less. So in these patients, perhaps taking a little bit of extra limbal tissue gives you a better chance of corneal healing faster than the conjunctival healing, and therefore the chances of conjunctivalization spreading over the corneal surface is much less.
And in chemical injuries, even in milder injuries, would you suggest doing a amniotic membrane, or you would say medical management? And when do you decide on when you would actually put any EM in those cases?
Sorry. I think in mild cases, amniotic membrane is not required. You can wait and see the response to steroids. Sometimes we are very hesitant to start steroids in the early first week, and that is where we lose the battle. So in mild to moderate, first you can give a 3 to 5 days interval and look at the inflammation, how it is being controlled with the help of steroids, and then decide. Especially if you see that the epithelial defect is not healing, there are signs of slowing down of healing, then again it's better to switch to amniotic membrane.
So, Dr. Dipinder, so just another basic question. I think Dr. Sandeep had highlighted a few of the benefits of, or the advantages or pathomorphological features of amniotic membrane being pluripotent, acts as a scaffold and everything. So, basically between you and Dr. Rushad, I think just want to ask that what are the factors which help you, decide or makes this the better biological than other like allograft or something like that? So what are the basic factors which makes amniotic membrane grafting or amniotic membrane per se a better biological tool in anterior segment pathologies?
So amniotic membrane is basically a template. Okay, it provides you an opportunity to cover the surface which is denuded right now, and you expect the body's healing response to cover it with its own epithelium. Whenever there is a situation that potential for the body to cover it with its own epithelium is poor, that is where you need a graft. This could be a conjunctival graft, if it is primarily a conjunctival healing issue. This could be a limbal graft when you expect that there is a limbal stem cell deficiency. Even a mucous membrane graft may be useful, especially when it's a bilateral condition or when there is extensive scarring. The only problem with mucous membrane grafting is the persistence of the reddish hue of the mucous membrane which lasts. But an additional advantage of mucous membrane graft is that it brings along with it minor salivary glands, and therefore there is better goblet cell density in these patients. that helps in subsequent dry eye issues which will come in these patients.
So AMG is kind of the first line of treatment, and then subsequently you have to see what to do next. It's your first opportunity to kind of heal the surface, let the surface heal on its own, actually.
Right. Thank you. So with that, now we move on to the next section, which is basically posterior segment, and something which I do know a bit about. So for that, I would like to invite Dr. Darius Shroff. He's a vitreoretina surgeon at Shroff Eye Centers, and he'll be talking about the newer indications, which is amniotic membrane grafting in recurrent macular holes.
So good morning, everyone. I'd like to thank the scientific community for this opportunity. So now we're going to move right on from the anterior segment right into the retina and dive into the retina. And we've covered this into two segments. I'll be discussing macular holes, recurrent macular holes basically, and Dr. Gagan Bhatia will be talking about optic disc pitch. So like Dr. Rushad said, retina doctors have stolen the amniotic membrane from them, and now they're using it for their cases. So let's see how useful it is. So basically, although macular hole surgery has got very refined and we have primary closure rates of more than 90%, we have certain cases where we do need help. We need something to help close these holes. So basically, recurrent macular holes where ILM is already peeled. So this is where the inverted ILM flap is not possible. And sometimes you have very high myopes, like you can see in this picture here. So this is another case where the contour of the eye makes it very difficult for the hole to close. We were always very curious to use ham in challenging situations like these. We tried a couple of times but found it very, very difficult to handle. What are the challenges faced when we use amniotic membrane in the posterior segment? We saw beautiful videos from Dr. Rushad and Dr. Dipinder. So for them, it's easy to use because they're putting it on the surface. But for us, as retina surgeons, we found it difficult to visualize because it's transparent and thin, difficult to visualize extraocularly, and intraocularly with high myopes, it has a very poor contrast. So first was visualization. Second is sizing. So the sizing is irregular and arbitrary, which leads to non-optimal grafting. So that was the second option. And the third was very important, placement. It's sticky, it sticks to forceps, and is difficult to place accurately. And if you just shove it into the hole with the forceps, you have a potential of damaging the RP layer. So because of this, we came up with this SSS toolkit for ham grafting. I discussed with my friend Dr. Dilraj Grewal and Dr. Gagan Bhatia. So we planned a workaround for each step. So this was an easy technique developed by us, so I'd like to discuss it with you. So can I have the music also? Can I have the
Audio
music?
visual, can you play the sound, please?
Yeah, so this is the toolkit. So it contains of the die, the tools we use for this technique. So let's go on. So you can see how difficult it is to visualize. It's transparent and it's basically invisible. So this is the problem, and let's see the solution. So solution is to stain it. So we use brilliant blue dye, and you see how this transparent membrane suddenly becomes visible with the dye. So what we do is we stain it, and then we copiously wash off the stain multiple times. And just this simple act makes it so much easier to handle. The second, shaping and sizing. So see on your left side how inelegant this is, cutting it with scissors. You have ragged edges which can get stuck in the ports. So firstly we size it by using this formula. So we add the base diameter with the MLD and divide it by 2. So this formula helps you to decide what size of membrane you need. Optic disc pitch, Dr. Gagan will be discussing with you. And then you see these are very simple dermal trephines which are very cheap, very easily available, and you just use this to punch and get the optimal size graft. So this was a very simple solution of a problem. Third is placement. So placing it is always an issue. So you see the forceps, it gets stuck, it doesn't come off, so it's really not very elegant to use. So we've discussed and we devised the sliding technique. So here we use a bimanual technique, put a chandelier, and one hand you can have the Thanos, and one hand you can have the nitinol loop, or you can have both hands you can use the flex loop if you like, and see how elegantly you can put the amniotic membrane using this technique. So let's discuss a case. So this is like a very scary high myope of axial length 30 millimeters, had a recurrent RD with a macular hole, and she lost vision post SOR. You can see this huge macular hole and a total detachment. So we did a revitrectomy with tug of war for the membranes, etc. Did a RR and placed a 3 millimeter graft. So I'll just show you the video. So you can see here, there are some membranes, there's some posterior hyaloid, so we remove that. And then we find that this is really difficult area, very, very tight. So in this situation, it's better to do a relaxing retinotomy. And with cautery, we're marking out these areas. And then we have to reflect the retina because there's some subretinal membranes and bands. So we remove the bands and membranes. Always be generous with your retinotomy. Once you decide to do it, you can make a larger one. So this is, and then under PFCL, we are unrolling the retina. Now you can see carefully the membrane. This is the amniotic membrane being taken out from the punch. And here you can see we have used 23 gauge for two reasons. One is high myope, and second is to get this membrane goes through much more easily in a 23 rather than 25. Sometimes in 25 it gets stuck in the ports. And this is the bimanual technique. So with the with a nitinol loop and a tannos, we are kind of unrolling it. And sometimes it crumples up very badly, and if you use forceps, it can be very rough. So this is the way we kind of unroll the amniotic membrane. And then we do the laser and a lot of relief at this stage, and we do the PFCL oil exchange. So this is the last step of the surgery. And a beautiful result. So you can see up is the post-op picture. The retina is stable. Vision has gone from hand movements to 6/60. And you can see how beautiful the OCT is on top with the closed macular hole with the graft. So this is a technique we published along with our colleagues from Duke Eye Hospital in the US, the staining and sizing technique for human amniotic graft in refractory macular holes. And this was published in JVRD recently, and these were the patients who were included. So I would encourage you to go through the full text of this article. So just to end, macular hole surgery is standardized and simple, but still we have challenging situations, and AMG offers a wonderful scaffold tool for these cases. Thank you.
Dr. Darius, it may be a stupid question to ask, but tell me, can you use the retina tissue in place of amniotic membrane because you're doing retinotomies and
Yes, so that's not, in fact, it's a well-established technique of using a retina autograft. But sometimes when I find if they're very high myopes, etc., we always taught to kind of save the retina. So if you have very high myope, you want the procedure to be as short as possible. So that does take time, little chance of bleeding is there. And if you have a macular hole, recurrent macular hole in attached retina, then you have to make a bleb, detach the retina and cut it, which is cumbersome, whereas this is available freely, you can just put it in. So it's a more quick in, quick out kind of procedure.
Another question, so we've seen when we stain capsules with trypan blue, the elasticity and the tensile strength changes. So have you all seen anything in that comparing? It would be worth actually seeing that.
We didn't think, I mean, I don't
think so.
I
think the basic answer to this first question, to the question is that I think, as you said, that we took over the amniotic membrane graft. So I think you need to appreciate the fact that we basically took a city car and turned it into an AMG, a Mercedes, much more suave. So I think it's a very tiny tissue. So I don't think the tensility and everything can really be, I don't think it can be adjudged as such. But the experiments that we did, with the membrane outside and as well inside, I don't think that with that size of a graft, we've been able to see any difference per se.
I want to ask the cornea colleagues, how long does the amniotic membrane last in your cases?
Few weeks typically.
Yeah. If there is inflammation, maybe just a matter of few days, because basically the protein of the basement membrane is rapidly digested by the neutrophils which are there. And in patients in which there is no very active inflammation, then yes, it will last for anywhere from 2 to 6 weeks also.
Because we have patients over 6 years and the membrane does, you still see that
Yeah.
white reflex. So 5, 6 years we are still, so we don't know what the endpoint in retina.
So I think the one more point that I wanted to discuss, which was I think spoken about in Dr. Rushad's presentation. I didn't ask it then, kept it for now. So you had spoken about using amniotic membrane grafts for non-healing epithelial defects, basically. So when we use amniotic membrane grafts in the center of the cornea, and what about the transparency? Because that is one basic point that everybody asks when we are using it in in macular holes. Because ultimately, if you see even the cases with Dr. Darius have presented, I think there is increase in vision, and even with so how does that translate? I mean, if it's just acting as an opaque scaffold, or it does clear out and lets you have some vision.
So anyway, it gets absorbed over a period of time. So for us, it's mainly a scaffold, and the host's epithelium grows and covers up the epithelial defect, and the amniotic membrane dissolves over a period of time, and we remove it. So I think it's pretty much that happens.
Right.
It doesn't persist in the epithelial defect actually.
Yeah, maybe because that was also what we've seen, like people who, I mean, there are reports where people have used the amniotic membrane as an overlay and macular holes. And if you see the membrane which is over the retinal tissue, that starts to kind of roll up. But probably the inlay, probably on the RP, it kind of stays because there is nothing growing under it, probably. That could be one of the answers. Yes, sir, please.
Sir, do you see a role of AMG in dry eye diseases as a primary go-to therapy?
So in very severe dry eye patients who are not responding to copious lubrication and even a bandage contact lens, sometimes you can combine it with a tarsorrhaphy along with the punctal cautery, because amniotic membrane does have, it retains the moisture better because of its nature, and it can provide you relief for maybe around couple of weeks and can help you tide over that extreme amount of surface erosions which come in these severe dry eye.
So if we have started cyclosporin, after that also it will reduce the inflammation, or you combine it with AMG and cyclosporin?
So the topical treatment would be definitely what you would do first. In a very severe dry eye, you can look at things like serum eye drops as well. We prepare it routinely for our severe aqueous deficient dry eyes, and that's what we use. The AMG is more a last resort, and then of course you would combine it with things like mucous membrane grafting as well for dry eye. You can use that. That tends to work better. Our group is not doing work on salivary gland transplantation, but that is also one method of counteracting the dry eye. The AMG, like Dr. Dipinder mentioned, is an initial thing to tide over the inflammation and give you time to again go in with a secondary procedure. Topical therapies now with things like liftigrast available, cyclosporin, you would definitely start with that. In aqueous deficiency, serum eye drops tends to work well. Systemically, you can give pilocarpine tablets. Again, those have a plus-minus role in aqueous deficiency dry eye, but those can be tried.
Thank you.
So basically, amniotic membrane brings along a lot of growth factors, and these growth factors, they help the epithelium to regenerate faster. But obviously, it's a temporary thing, but helps you tide over that crisis time when the dry eye is very severe.
So right now we are seeing so many ITP people are coming with dry eye problem, and they are very much pertinent about our MGDs will go and our symptoms will reduce and these things will go, and they are very much aggressive about their treatments also. They'll read on net and they'll come why can't you do this transplant to us? So what is your opinion about that? We had some patients, nursing staff and all that, they'll be very keen about this amniotic membrane transplant.
No, I think we have to be very scientific in our approach, and we have to respect the limits of any particular medical therapy, and amniotic membrane, the decision has to be taken based on the clinical findings only. Thank you.
Now we move on, and the second indication where we found amniotic membrane very, very useful was in a pathology which is very difficult to treat, which is optic disc pit maculopathy, because it reacts in a very variable manner. So Dr. Gagan will take us through this topic.
Thank you, everyone, and I would like to thank again the AIOS Scientific Committee for this IC. And so amniotic membrane grafting and optic disc pit maculopathy. So basically, optic disc pits is a congenital abnormality which is rarely seen in almost 1 in 10,000 eyes, and probably happens because of improper closure of the optic fissure. It is optic disc maculopathy basically is a serous detachment of the macula and retinoschisis, which happens in almost 50% cases with optic disc pits, and if left untreated can really get the vision down. So this thing is very controversial as to where the fluid comes in from. There are various theories. Some say that it is through the vitreous, some say it is CSF, and some also postulate that the leaky blood vessels are the defect, which are there, though, and there are a mechanism of vitreous traction and pressure gradients within the eye which also contribute to this. So if you see the morphology of optic disc pit, the macular area would basically show a schisis of the inner layers, and then it can also show an outer macular hole and an outer retinal detachment on a neurosensory detachment. So as far as management is concerned, again, it is basically about drying the macula and decreasing the traction. So pars plana vitrectomy is the mainstay. Basically, that means inducing posterior hyaloid separation, and also has been juxtapapillary laser again to cause a barrage between the disc and the macular area, and optic neurotomy and inner retinal festration, which are not very, very famous. Then came the area where they started stuffing it. So basically, you do induce a PVD, and then you stuff the hole so as to again cause a barrage. And the most studied ones are ILM and newly now as sclera, which has been used. And we'll be talking about amniotic membrane grafting. So AMG grafting for disc pits was first popularized by Dr. Rizzo and his team with 3 patients of 3 eyes, and he presented his 6 months follow-up in retina, and that is what inspired us to go ahead and start using these membrane grafts in our patients. So this has already been covered by Dr. Darius. We again use the same technique to kind of size them and stain them. So after inducing a PVD in a case of disc pit, we go ahead with the core vitrectomy and also do a base shave as much as possible. The ILM is stained, and after staining, it is very imperative that you do a very careful ILM peeling in these cases, because you don't want to create a macular hole, and also do a macular sparing peel. There is always a lot of fluid under it, and there is schisis, and the retina is pretty thin. So after we do a ILM peel, and always leave, in our technique, we leave a little scuff at the disc margin. This is covered by Dr. Darius. We stain the graft so in these cases of disc pits, we measure the maximum linear diameter, and then a trephine is used to take the graft. Again, 23 gauge sclerotomies are the best to use because they go through well, and they don't crush the graft, or the graft doesn't get stuck. Again, bimanual technique to kind of release the graft from the fossa, but you'd see that it is a bit difficult to do that. And then finally, it is placed in the disc pit area bimanually using a nitinol loop and a blunt Tano scraper. Would not advise using a forceps because it can sometimes can lead to a peripapillary damage. Then the cuff of ILM, which is left behind, we just kind of peel it as a disc-based flap, and just to keep the ILM in place. At that point, we complete the ILM peeling, a macular sparing peeling, and then finally do a gas exchange. So we kind of collated our data and present this 5 eyes at present, and there was a female preponderance, and the mean age was around 30 years, with left eye being more prevalent. The mean horizontal diameter of these pits was roughly around 784 microns, and duration of around 5 months, plus minus 10 months. And retinoschisis and SRF, as the stages goes, were present in almost all eyes. So the visual acuity gain was significant from 1 logmar to almost 0.5 logmar, and there was a drastic reduction of the central macular thickness from almost 900 microns to 198 microns, and most of the cases basically showed a rapid reduction in fluid ranging between 2 to 4 months. So this is the first case which I'm showing. This was the first case which we had done, and this was of a pediatric girl who presented with a disc pit, and the visual acuity was roughly around 6 to 20 by 80, and the linear diameter was again 926 microns. We used a 1 mm trephine to do this, And if you see over 3 months period, there was absolute flattening of the macula, and there was no fluid present, and the vision almost improved to 6/9. And over 3 years, now it's around 6/6. So this is the second case. Again, why I included this case is because this is a recurrent pit. So this lady, again, she had a juxtapapillary laser elsewhere, which was the norm when she was probably 13 or 14 years old. And then she presented to me somewhere around 4 or 5 years ago, 3 to 4 years ago, when she had this recurrence. We followed her up because it is important to realize that don't go into these cases immediately, because sometimes they do maintain very good vision. They have a waxing waning kind of a period, and only when she had this drop in vision to 6/36, we went ahead and did the procedure. So with gas in situ on day 2, you see a rapid flattening of the fovea. And if you see the AMG is still in situ at 2 months, so this is a pointer for Dr. Roshad and Dr. Darius and Dr. Dipinder. And there was reduction in the NSD as well as the schisis. Over 8-month period, you can again, if you see the top left hand corner image and also the OCT scan, the AMG is still in situ and it's not absorbed. And the foveal contour is well maintained. There is no NSD and vision improved to 6/12. This third case, the reason for including this case for presentation today is because I remember when I had presented my first case, which was a solitary case at a meeting, I was basically asked, I was given a comment that, don't you think that you're just lucky? So that is because, ILM peeling and PVD induction were the mainstay of treatment even before. And I see Dr. Charu also here laughing because he also believes in that. But so the reason for including this case is because, yes, AMG does make a very big difference. So in this case of a 15-year-old male, again, we saw that this case had everything. It had an NSD, it has an itomacular hole and schisis. So we went inside, we did a AMG. The AMG is still in situ, but if you actually see the cut, it is kind of, as the gas is reducing, the AMG is also flowing away. So, and surprisingly, at 8 weeks, when the gas went away, if you see where the AMG is gone, it's gone to the nasal side and the fluid has come back. So I think this case was included basically to show that AMG, yes, definitely plays a very important role in addition to the macular-sparing peel and PVD induction in these cases. So in a mean follow-up of around 11 months, the visual acuity is around 0.5 logmar with a CMT reduction of 128. The NSD resolved in almost 60% of eyes. And schisis in almost 40%, and the AMG was in situ in 80% of eyes. Because this data is only of 5 patients, so obviously the percentage difference is large. But if we compare it to, again, back to Dr. Rizzo and Caprosi, their team, they also presented their data with 11 eyes, which was a 1-year follow-up, almost similar to our last follow-up of 11 months. And in their case also, if you see that the reduction in CMT is almost the same as our study, and the visual acuity improvement also seems to be almost same. And there was complete resolution again in 9 of 11 eyes, where in our eyes also there was, because the graft went away, there was lesser resolution in that patient. So I believe that, to conclude, that human amniotic membrane grafting definitely is helping in these cases in macular holes as well as in optic disc pit. And yes, a larger comparative series is definitely required to establish the role further. Thank you.
Thank you, Dr. Gagan. So do you think you are doing it in primary cases, and should amniotic be used in all pit cases, or would you first like to do the ILM?
So I would like to put it this way, that I would not want to intervene in an eye which has very good vision. That is number one. And secondly, as of today, looking at this data, I think I would definitely keep AMG as the first choice in my armamentarium for sure. Yeah, because it's not like ILM stuffing doesn't work. There's a huge amount of data and work on ILM stuffing as well. But then that ILM stuffing sometimes does tend to go away. And those short series, but AMG, definitely is staying there, which is very contradictory to what Dr. Rushad and Dr. Dipinder were pointing out to. So probably again, the one point which I picked up, and maybe I'll go back and literature search this also, is that that probably it's some sort of a basement membrane that starts growing under, which gets the amniotic membrane to go away. And probably in our cases, because it's just a pure scaffold and there's nothing growing there, maybe it's not. And if you even, as I spoke about overlay techniques, that it starts the epiretinal part starts to kind of go away. And as Dr. Carlos has also showed in his cases, it's the part which is in the macular area, inside the macular hole, which does not tend to go away. So probably it's something that stays for a longer time and probably would kind of suffice to us needs, especially in these cases.
And do you also drain the fluid from the pit?
No, no, we don't drain that fluid from the pit. None of these cases we actively drain the fluid.
What about other graft material like sclera? And I think Dr. Dipender was suggesting using tenons. I don't know what. It's not on mic.
Hello.
Yeah.
Any role of autologous blood over the pit or fibrin glue?
Yeah, so there are single case reports of autologous bloods always as this thing, but then all those techniques have again used an ILM flap. So they probably just use the blood to secure the flap in place,
Yeah.
and not that they have primarily been as like this thing. Glue again will kind of go away, and so then again that will be temporary. So I think sclera is something that is again permanent, but again harvesting the sclera and then that is something little challenging because usually as retinal surgeons, yes, though we are kind of used to doing scleral buckles and doing a cut down, but I don't think I would want to make another hole in the eye which already has a hole inside. Yeah.
Any questions from the audience or from the panel? Okay. So thank you everyone for coming here on Sunday morning. I think it was a nice course. And have a photo, please.
Yeah.